Sir.
In fact, the first discussion which we had in the previous one, that is exactly what is the first examiner is going to ask. And that was exact time also, 30 minutes. It was exactly at 30 minutes, I stopped it. And I'm going to stop the discussion. This discussion also is exactly at 30 minutes. Because that is the way you're going to be examined. Okay. So what investigations you would like to do?
Sir, first of all, I would like to do baseline investigation. Then I will do the diagnostic investigation, and then I will do the staging and the severity investigations.
Okay.
Sir, in baseline investigation, sir.
So what is this thing called as?
This whole set of investigation, sir.
What do you call this thing?
Sir, first I will do the triple assessment of the breast cancer, sir.
Now remember this thing, that in investigation in the breast, irrespective of symptom, the first thing is the triple assessment. That is the first thing. Whether you have lump, you don't have lump, the symptom could be as simple as pain abdomen, pain in the breast, whatever it is. If the age group is such that the patient could have a carcinoma of the breast, then triple assessment straight away. So what you want to do? Which investigation?
Sir, in the triple assessment, the first part is done, history and examination.
Very right.
Now coming to the imaging investigation. As she is 65 years old, so my first investigation of choice will be mammography, and mammography of the both breast, the right and the left, both. Sir, in mammography, there are two views. One is medial lateral oblique, and the second one is the craniocaudal. In craniocaudal view, the extent of tumor from the cranium to the caudal region is identified. In the mediolateral oblique view, the mediolateral and the axillary lymph nodes, they are visualized in this mammography. So this is the first investigation.
So why in this case you are preferring mammography?
Sir, because she is 65 years old. The breast in this age is lesser dense as compared to the premenopausal state. So that's why mammography is the preferable. And at the same time, the other breast is also screened, screening mammography of the left breast. Sir.
Okay, tell me what are the findings in mammography, which is going to tell you that this could be carcinoma?
Sir, number one, I will like to see whether there is a mass or not. If there is a mass, then I will go to see the size. The higher the size, the higher will be the mass. Then the texture of the mass can be identified in malignant breast. In malignancy, the texture is denser as compared to the benign diseases. Then there will be calcifications of the mass. This will be speculated or microcalcifications. These sorts of calcification will be present. And at the same time, I will see the axillary lymph nodes. And if that is also positive, so that is also pointing towards the malignancy. So these are some points in the mammographic finding of carcinomas.
Let me give you some information also. You see, if there is a mass, it could be benign or malignant. That is this. Now see how mass, if the shadow is well defined, if the margins are well defined, and especially if you see a hollow around it, that means benign. In case it is cancer, what you are going to see is architectural abnormality. As you're comparing with the normal breast, then near the tumor, the architecture abnormality would be seen. It means the shadows which are around this thing, the mass, they are going to say abnormality. Not only this, if it is the mass which is speculated, speculation agar nazar aa rahi hai, then that is a cancer. And microcalcification. Microcalcification could be in form of cluster, मतलब dot dot dots पड़े हुए हैं, that's a cluster, or it could be linear, the dots are going in a line, or it could be branched. It means as a branch it is going. So it's a microcalcification. These things are present. Then that is going to suggest it could be malignancy. Okay. What other investigation?
Sir, regarding imaging, this is the investigation. Now I would like to do to confirm by the biopsy, sir. I would like to do the biopsy,
Which
and once
biopsy?
it is confirmed,
Which biopsy?
sir, true cut biopsy is the ideal choice in this case, sir,
Why?
because it will give me adequate amount of tissue, and on that tissue I could be able to do the receptor status, ER, PR, HER2, NIV, and all these things, sir.
Very
So
true.
that is my first, sir.
Now this thing is he's talking right. So therefore, and before that, nowadays usually both ultrasound and mammography are done together, which is called a
Sir.
sonomammography. But obviously, mammography should be the first answer, and sonomammography means then obviously one is going to ask is sonomammography, which is the more important component. So you in this case are going to say mammography. That is very good. True cut biopsy is to be done because true cut biopsy as compared to FNAC has two advantages, not one. Number one, the true cut biopsy tells you about the architecture also in the true cut. It is the architecture which tells you which type of carcinoma it is. FNAC only gives you cells. In cells, you can only tell it's a carcinoma, but you cannot tell which type of histological carcinoma it is. And then in true cut biopsy, there's a piece. So therefore, you can do the status much more easily as compared to FNAC, because in FSC also there are cells are present, and that cell could be clustered by different techniques, and then one can also do hormonal receptors assessment. But obviously, true cut biopsy, that is the advantage. You have done the radiological assessment and it has confirmed it's a carcinoma breast.
Sir.
So what you want to do now?
Sir, now I will like to see the staging and severity of disease, sir.
Okay.
I would like to do this, sir.
Which investigation?
Sir, for that I will do CCT chest, abdomen, and pelvis, sir. And if I have any suspicious regarding the bone, then I will first do the X-ray of that bone, and if that is become suspicious, I will go for bone scan, sir. As in this case, she is also complaining of back pain, so a screening X-ray of the back can give me a clue whether I should go for bone scan or not, sir. The CT scan of the chest and along with the abdomen, the thoracic wall and the abdomen will rule out the metastasis in the chest and the abdomen and also the pelvis.
Well, that is correct. Only thing possible is that if you are suspecting tumor in the bone, then bone scan would be the investigation of choice, not X-ray, because X-ray is going to pick up very late. So bone scan. Right. That is a preference. That's a different issue, that if bone scan is not available, there's a lot of time, there's a delayed mirror to up scan karwa lein. And similarly, CT chest for lung mets is the treatment of choice now. But if it's not available, then X-ray chest PAU, that's okay. And the CT scan abdomen, that's a correct answer. Again, second line would be ultrasound liver for liver mets, again provided same if the things are not available there. So what you're going to do now?
Sir, after knowing the baseline status, the extent of the disease, and the diagnosis, I will arrange for a multidisciplinary team meeting, sir, to go for the treatment of this patient.
And what the team is going to do?
Sir, surgeon, me, myself, the radiologist, the pathologist, the oncologist. So this will be consisting of the team, sir. And if the rehab specialist and the psychotherapist are available, so I will also involve them, sir.
So what is going to be the treatment?
Sir, sir, based upon the staging, as this is already a stage 3 disease, so I will first request the oncologist to go for new adjuvant therapy.
ये जरा बंद
Hello, sir.
कीजिएगा। मैं प्लीज अनम्यूट करें फहद, अपने उसको अनम्यूट कीजिए, म्यूट कीजिए फहद। एंड नहीं, ठीक है, फहद ही थे। इट्स ओके। So you want to do a neoadjuvant chemotherapy, and after neoadjuvant chemotherapy,
After that new adjuvant chemotherapy, sir, the oncologist will assess the patient as per RECIST criteria. And if the tumor is responding to new adjuvant therapy, then he or she, whatever the oncologist is, will advise the surgery. And
which surgery you
after
would
the
like to, which
surgery,
surgery you would like to do?
sir, if there is, in this case, I will go for a modified radical mastectomy, sir, MRM,
And
sir.
modified radical mastectomy, what you are going to remove?
Sir, the tumor mass, the nipple areola complex, wide local excision of the tumor, the whole breast and its tissue, along with the axillary lymph nodes, sir, and the extent of the disease is from the lateral border of the sternum to the interior border of latissimus dorsi muscle, and it goes up to the axillary veins.
After
And
after mastectomy, what you want to do? Modified radical mastectomy. Then next step.
Sir, this I will send this tissue for histopathology, and the histopathologist will again give me the report. What is the type of cancer? What is the grade of
It is
cancer?
confirmed.
What?
It is confirmed. It's T4. It is confirmed.
Sir,
It is T4. It is T4 T0.
sir, in the histopathology, the histopathology also gives me the stage of the disease, the
Oncologist.
proliferation, and the histo, and then and he will give me again the status, and then I will refer the patient again to the oncologist for adjuvant chemoradios.
So you want to give now adjuvant chemotherapy, and you want to give radiation. And which part you want to give radiation?
Sir, the right breast area, sir.
Chest wall.
And what
Chest wall,
about
yes, sir.
your axilla?
No.
Sir, axilla, if it is positive, then if there are more than 4 lymph nodes involved, then I will go for radio. Otherwise, it is not routinely indicated because of the extreme mortality and morbidity, sir.
Okay. Then after chemotherapy, what you're going to do?
Sir, a follow-up of the patient, sir.
So after chemotherapy, you're going to do follow-up.
Sir, regular follow-up of the patient.
Nothing else.
If the patient wants, I can involve the plastic surgeon for
Reconstruction.
reconstruction.
No, forget about this.
Reconstruction.
You're going to involve this or this and these things.
Sir,
Forget
sir.
about talking like
So,
that. I want what you want to do. So do not talk now again in these words so much. What you want
right,
to
sir. A reconstruction of the breast, sir.
No, I'm not talking about surgical procedure. Do you want to do anything, or do you want to give some hormonal treatment, or don't want to give any hormonal treatment?
Yes, sir. Yes, sir. If she is ERPR positive, then I will go depending upon the status, tamoxifen or anastrozole to the patient. And
Either
if she
he is estrogen receptor positive,
sir,
what you want to give?
anastrozole, sir.
Estradiol you want to give. For how much time?
Sir, some books say 3 years, some books say 5 years, but I will go for 5 years.
We'll go for 5 years.
Sir.
So now I have got a general idea that how he wants to treat the case of locally advanced carcinoma breast, and that is true. First, any patient locally advanced neoadjuvant chemotherapy, then surgery, then adjuvant chemotherapy and radiation, and then hormonal treatment. This is how it is treated. Now, tell me this thing, which I want to ask is,
Sir.
okay. Let me start with your what you're talking about is and in modified radical mastectomy, you are saying you are talking correctly. But even if you say
Sir.
the whole breast will be removed, then it
Sir.
will include the lump. And what you're talking about, it is excised.
Sir. Sir, basically in modified radical mastectomy, we remove whole of the breast tissue, the nipple areola complex, the skin overlying it, and also the level 1 and the level 2 axillary lymph nodes, sir.
Okay. Now let me explore a little more. You have started the neoadjuvant chemotherapy.
Sir.
What you will do? Today you have started the neoadjuvant chemotherapy. What you're going to do?
Regarding the
Management.
Sir, after 2 cycles, we will reassess the like response of the to the chemotherapy after 2 or 3 cycles of the chemotherapy.
And then
Sir, if
Sir,
the response is good, then we will continue with that. If not, then we can consider the surgery first after that adjuvant chemotherapy.
and
Rest
if
of
you
the
want to
cycles.
continue, how many cycles are you going to give?
Sir, up to 8 cycles are given usually.
Okay, good. So that is correct. After 2 weeks of chemotherapy or third week, 2 weeks of third cycle of chemotherapy, the response is seen. And if the response is present, that means that a cancer response is responsive, and you add 6 cycles more to it. So totally around about 8 cycles are given. And after that, obviously, you're going to do the modified radical mastectomy. Now, if there is no response to chemotherapy, then the treatment would be correct, that one should go straightly and one should operate the case.
sir.
The only thing to remember is, if the cancer is inoperable, then drugs might be changed. There's a difference between a tumor which is operable, with a tumor which is inoperable, and once the tumor is inoperable and it's not responding to chemotherapy of 3 cycles in neoadjuvant, then we might change the drugs and see the response. Okay. Now, what you're going to do after 8 weeks of chemotherapy. So today is the day that 8 weeks have finished. Sorry, the 6 cycles have finished. 8 cycles have finished, and the patient has come to you. Then you're going to do the surgery.
Sir, we will restage the disease.
Even if you restage the disease, the surgery is still to be done.
Yes, sir.
So
So we will. Sorry, sir.
Today the patient has come, and you have to give him date for the operation. So what date you will give?
Yeah.
Also including the chemotherapy time period, sir.
No, chemotherapy to khatam ho gayi hai. Chemotherapy is finished.
Chemotherapy भी हो गई और surgery भी होगी, sir.
नहीं, surgery नहीं हुई, surgery की date
Surgery
देनी
date
है.
देनी.
ठीक ठीक
After
Sir,
ठीक.
I want to add
usually
something.
4 weeks, sir.
In case of new adjuvant,
Within
That's
4
right.
to 6 weeks.
Somebody is given the right answer. After 4 weeks.
Yes.
So today is
4 weeks.
Okay.
4 weeks.
4 weeks. So today is 23rd. So you're going to give the date of 23rd of February to operate the patient.
February.
Okay.
And although even if, let us say 4 to 6 weeks here, that's perfectly okay. But you will give one answer. You cannot give 2 answers. You cannot say to the patient, okay, I'm going to operate you on 4 weeks or 6 weeks. No. But I mean to say, in examination, if there is a range of time period, and since you're talking about the patient lying in front of you, then you are going to give one answer out of the two. If both are correct, you can choose anyone. It hardly makes a difference. And why you want to give? Why not? Patient is so tense, operate him next week. Why you want for 4 weeks?
Sir, in case of 4 weeks, the platelets and CBC count and all that can be corrected, and the patient become fit and within a 4 weeks.
Okay. Okay. The tumor has come when she has come after 8 weeks and you have reassessed, and to your surprise, there is no tumor in this patient. What you're going to do?
MRI.
So
Sir,
still we will go with modified radical mastectomy. But if we want to, we should have done the clipping initially before the chemotherapy, before sending the patient to chemotherapy, so that we can have a clear margin. But not in this case, like it is going to be MRMs.
Very true. So the concept is the treatment is going to be modified radical mastectomy. Let us say if there was no tumor, breast conservation surgery is only done if clipping has been done. Because in breast
sorry
conservation,
sir, आपकी आवाज सर बहुत
अब आ रही है आपको? आवाज आ रही?
Yes, sir, हमें आ रही है.
आपको आ रही है? ठीक. So what I was talking about is जो आप बात कर रहे हैं कि a tumor which disappears completely because of chemotherapeutic response, then breast conservation is allowed if a clipping has been done that is showing where the tumor was. Otherwise, one cannot do a breast conservation surgery. Okay, now it has been done. So the next thing is, you want to give radiation or don't want to give radiation to this patient?
सर आवाज थोड़ी कट के आ रही है सर.
After MRM, the radiation should be given to the chest wall and wound bed.
And what
If
about
no
axilla?
immediate reconstruction was planned.
The concept of giving radiation is if there are high chances of recurrence locally, then obviously you're going to give radiation to the area. It's a locally advanced cancer, and you have done modified radical mastectomy. Now, if you've done modified radical mastectomy, the thing to see is whether modified radical mastectomy lymph node clearance is adequate or not, which means you have removed at least 14 lymph nodes in the axilla. If the 14 lymph nodes have been removed, then radiation to chest in the breast floor is required. But if MRM tells you that adequate lymph node clearance has not been achieved because of any reason, then one will have to add, in this case, radiation to the axilla also. And after that, obviously, with that is the chemotherapy, and you are going to do a chemotherapy. And how many cycles you are going to do of chemotherapy now?
Sir, I want to add something. If there is a plan for new adjuvant 4 cycle before and then surgery and then 4 cycles, so it makes total 8 cycle. And the response should be checked after 2 cycle
Totally.
in case of new adjuvant.
Very true.
बात हो गई.
The new adjuvant, the concept is again same. In the half, one checks the response when the time is half of this thing. But in any case, now this discussion is, that means if the rest of the thing you are given correct answers, then you qualify to be passed. Nobody is going to fail you if you do not remember, do not tell exactly the cycles, even if you're telling rough cycles, if you have the concept of these things, then you pass. Two more questions, which time is running out, so I am asking two questions now. You have done mammography. So how do you classify mammography? What reporting is done? How reporting is done?
सर बायरेड क्लासिफिकेशन होती है सर उसके लिए सर.
And what is BIRAD?
Yeah, sir, the first one is inadequate study that requires further study. The mammography cannot pick. The other thing is benign findings, and the third one is atypical findings. The fourth one is suspicious of malignancy, and the next one is the malignant, and the last one is the proven malignancy. Tissue biopsy हो चुकी है already, और उसके लिए malignancy. So these are the 6 degrees, sir.
Now you see, that's what I was talking about. Now, if somebody has so much knowledge, it's very good. You don't require to be very precise. Like if you do not know, the BIRAD stand for breast imaging, reporting and database system. This classification is according to American College of Radiology. Even if you don't know, it hardly matters you know this thing or don't know this thing. R1 is normal. R1 is normal. Now, why the problem arises is because C1 is inadequate sample, whereas R1 is normal image. So since one is remembering C1, C2, C3, C4, C5, R1, R2, R2, so they tend to confuse each other. So sometimes these words get up mixed up. In BIRAD, we are going to talk about image. So R2 is benign looking image. And R3 is probably benign image. R4 is probably malignant image. R5 is highly suspicious malignant image. And R6 is proven on histology to be cancer. This is just for this thing. Okay, what is happening now is we are running out of time. So next week, what I want to do is I will do a next case. That would be good. That would be much better.
Sir, can I do that dysphagia case which I asked you to do?
Oh, sure, ma'am. Lovely. So the case is already booked for next week. So we are going to do a dysphagia case.
Sir, any update regarding the date of exam?
आपने जब ये शुरू हुआ तो आप लोग बात की तो मुझे ख्याल आया तो मैंने पता करना था भाई मुझे मैसेज जब ये शुरू हुई ना रिकॉर्डिंग जब मैं आया था उस वक्त पहली टॉक आपकी हुई थी किसी का कब हो रहा है तो उस वक्त मुझे ख्याल आया मैं तो भूल गया पूछना तो मैं सोच रहा था कि आपके ज़हन में मुझसे कोई सवाल पूछ के मुझे इतना शर्मिंदा ना कर पर आपने कर ही दिया है तो कोई बात नहीं जिंदगी में बिल्कुल माजरत नहीं मेरे भाई आदत है ये तो इस चीज की शर्मिंदा होने की कोई नई बात ही नहीं है भाई मुश्किलें इतनी पड़ी कि आसान हो गई दैट्स नॉट एन इशू मुझे मैसेज कर दीजिए
Sir, can I ask you a question about this patient the Dr. Ismail has presented?
जी प्लीज
Sir, like he said that the patient was having an ulcer and the lump was there for 1 year. The patient was having an ulcer and it was standard. Temperature was also like it was standard overall. Like when I was listening to the history, I thought it is inflammatory breast carcinoma if he is going towards that. So the patient is standard at this moment. Can I go for mammography because it's also itself a painful procedure? So why don't I do ultrasound first and then I give some painkillers and do the mammography within a week or so, 2 to 3 days? So like what about that? It will be painful for patients. So what should we do then?
When these questions were being asked, so it is understood the symptoms will be taken care of.
Okay. Okay.
अगर आप बताती हैं ये तो that's better. अच्छी बात है कि बताती हैं because मगर अगर आप नहीं बताते तो you have not lost much. This is what I mean to say. Now,
Okay, sir.
what you're talking about is inflammatory carcinoma.
Yes, sir. Like in this case, I thought it's inflammatory breast cancer because already ulceration and all that.
Now, inflammatory breast cancer, if you see, then you are right. History and examination looks like inflammation.
Ji, sir.
It is, the breast is painful, it is red, it is warm, and really you don't know it is mastitis or it's carcinoma.
Ji, sir.
And it is so malignant. It is so malignant that within 1 year, you are correct, the patient may not have been alive, or it may have eroded and it may have done these things also. The only thing to remember is, in carcinomatous, जो आपने कैंसर की बात की है, the inflammation is very pronounced. Is very pronounced.
Okay.
That is the only thing which differentiates it, but does not rule out. There's a separate thing.
Ji.
Other thing is that in carcinoma breast, the whole breast is like that. It is red, inflamed, edematous, like mastitis involving the breast. Whereas there's a mass. And when he was giving history, he was saying ulcer tender and this thing. Mass, he never said it's very tender. So that is how argument can be done. But if somebody is thinking about
sir, one of the reason of the pain is the skin, the nerves of the skin are involved because it has ulcerated into the skin. So the nerves of the skin are involved. That's why it is painful, sir.
Very true. Very true.
And due to the secondary infection, it will be painful.
Yes, sir. Yes, sir. It's secondary infection.
So basically what we were discussing is any case which has pain, which has inflammation, inflammatory signs and symptoms, signs, and they are predominant. And you cannot explain it is inflammation because of infection, because to your surprise, patient doesn't have leukocytosis, patient doesn't have neutrophilia, patient does not have high-grade fever. There's a mismatch. If there is such a severe inflammation, the breast is like a ball of inflammation, like mastitis, and patient is not giving history of fever.
Yes, sir.
Blood CP test is not showing neutrophilia. हालांकि इस केस में तो फीवर का होना ही होना चाहिए, and
होना चाहिए था, जी
और
सर.
neutrophilia होना चाहिए था. So then one can rule out these things. Okay, the time is getting out. So inshallah that has helped you. So see you next week. Have a good time. पकोड़े खाइए, मौसम बहुत अच्छा है. बनवाइए, जिनकी शादी हो गई है बेगम से बनवाएं, और जिनकी नहीं हुई खुद बनाएं और मौज करें.
सर जिनकी हुई है नहीं हुई बनाना मर्द नहीं है सर आजकल.
अगर कोई ना बना के दे रहा हो तो मेरे घर पे आ जाए.
सर एनसीबी इसीलिए रखे हुए हैं सर.
खुदा हाफिज.
सर थैंक यू, जज़ाकल्लाह.